we talked about the calls because.
Yeah, I already talked to him.
Oh, okay.
Yeah, I just came from there.
So
I just told him if the med students tell them nursing students like call this or replace anyone for this or whatever that. When they call on the phone, it's that they'll be asking for that deposit.
Okay, that's what it is. All right.
Because on our side, the students are very used to calling on the phone if there's any change of position, if there's any orders to be get. And last time it was like, I'm playing pretend, this is stupid, what am I doing? Now at least it's something.
Okay. Yeah, that's what this is good because we don't know that.
Right, yeah. No, I was explaining to them.
You got it?
Yeah. You know all the entries, did the two test, please?
Soon to be.
Don't worry, it's not graded. It's just for us.
Yeah, that's what I'm saying. I mean, part of your stress.
Did you do legacy login?
Yeah.
Yep, your password is your regular. Funny, our social.
I have one more group downstairs. Hopefully I'll be there, you know, when they need me.
The headache. I had this no diary.
Yeah, I think we were one more over.
Yeah, it was like, yeah. We were supposed to use it next week. So I work in a crowd downstairs as a manager. But our students are
I know, I want an ice cream social too. Okay.
So we're gonna have,
You want me to do introductions? Can I switch to the name or the?
ready?
You have to use a mic.
If you want. You have the lab?
Oh, it's there. It's on the. It's activated on the slide. I think that's all the groups. They're done. Might be one or more, two more. You know, I thought when I go introduce everyone. Communication. Are you ready? We're ready. You got all this through?
Is everyone done with the free test? Everyone done with the free test? Anyone working on it? Okay. A couple more minutes.
Yes.
So we're in a form of a pretest.
Yes, that's okay. We'll get full credit. We're just trying to gauge your knowledge of this stuff. We have enough.
Okay, you do.
I appreciate you having volunteer. Makes no difference. Yes. Oh, should I get a sheet of paper? Actually, yeah. You can leave a little early.
That are completely blank. You can select one of these.
No, I'm just gonna pass it. Or you want me to? I can look on.
Yeah.
The other pen.
No, I didn't bring it in here.
I have it.
They weren't on the invitation roster, but we might as well take it.
Anyone else working on it? No? Oh, you are?
This is
Someone's got a name so far.
I know.
because I assume. Students? I don't know unless you wanted to. Yeah, I assume. No, no. Yeah.
Alright guys, we're going to get started. I want to welcome you to Interprofessional Education with Chamberlain College of Nursing and Ross University School of Medicine. Yeah, that's okay. So to give you guys a background, this isn't something we get to do very often, so we get very excited when we get to have Ross, future MDs, and future RNs together to do a couple simulations. So to introduce myself, I'm Christina Artiles, Assistant Dean of Student Learning. I want to introduce you to my team. I have Evelyn Mathis, Student Learning Specialist, Alberto Moreno, and I have Terry Conti, also Student Learning Specialist, and my boss also, Associate Dean. We had Angie God, and Dean of Academic Affairs from Chamberlain College of Nursing, Sharon Rodriguez, and she'll be talking a little bit later. Good. Yeah, Dr. Nico.
All right. Hello, welcome everybody. Thank you for coming on a Friday afternoon to learn about interprofessional education. I'm Sean Nieko. I am a family physician and the director of IMF, which is where the medical students do their first clinical course this year. And I'm very excited to see this seating arrangement. Last time we had sort of one group here of blue scrubs and one group here of white coats, so it's much better this way. I can tell you I never took care of a patient that wasn't in collaboration with a nursing yes, or even, an MA, a clerk at the site of the hospital or at the clinic. And it's very important that we're trying to teach you how to practice medicine the way it's actually practiced when you graduate and move on to your career. That is one sort of blind spot in the education system. We're trying to correct that with this interprofessional education. So we'll get into that in a second. I want to introduce our team here. We have Dr. Rochford, Chair of Internal Medicine. Yes, you wave. Sorry. And we have Dr. Mafdali, Dr. Gadichan, Dr. Melendez, Dr. Watson. What else? Who do we have? Oh, yes, Manager Summation, Mariano. So I think we're going to get started with, I'm going to give you sort of an overview, some objectives that we're hoping to accomplish during this session. And as part of this, some of the values, just where you're sitting, getting to know each other, wonder, what stage of training you are, what you're interested in. Just the mingling during downtime is a good part of getting to know your co-workers and your co-students today. So I think Dr. Mafdali is up first. Teaching fellow, you're not.
Can everyone hear me, or should I use the mic? Everyone hear the mic hear me? All right, great. So thank you all for coming. This is exciting for all teams, and hopefully we get some good progress and a lot of learning out of this. So let's see. The idea is the interprofessional education objectives. We want to be able to recognize and apply the IPE core competencies. And in doing so, we want to understand the 4 core skills that make up the framework of team steps, and be able to recognize the differences between hospice and palliative care, and understand the nuances of working in a team composed of medical students and nursing students. Those 4 competencies are the values/ethics for interprofessional practice, the roles and responsibilities of everyone, how to communicate with through interprofessionals, and teamwork, and how to work in teams. So if we go a little bit more in depth about those, right? If you're thinking about the values and the ethics for interprofessional practice, you want to be able to work together with mutual respect and have the shared values, as everyone is a professional in their own field. The roles and responsibilities is having that shared acknowledgement of everyone participating and the team members' roles and abilities. Regarding the communication aspect, you want to do it in the most responsible and respectful manner possible that encourages a team approach. And when you're working as a team, you really want to apply relationship building and the principles of team and working on team dynamics. So here we're going to go over team steps. And it's pretty much a framework for nursing students and medical students to communicate and interact efficiently to maximize patient care and reduce medical errors. Because a lot of medical errors can be reduced based on efficient communication and appropriate handoffs. So we have leadership, situational monitoring, mutual support, communication, knowledge, attitude, and performance. And we're going to be going through all of these.
And let me just add, if you don't mind,
yes,
going back to the acronym team steps. The last component there is team strategies and tools to enhance performance and patient safety. So it's been known for several years that one of the leading causes of medical errors is lack of communication across teams, not the knowledge of who's providing, but how they work to provide that care. And medical errors, depending on how you calculate that statistic, could be considered the fourth leading cause of death. So as much as we're trying to help our patients by not communicating and working as a team, that is one of the most common causes of medical errors. So part of this whole initiative is to solve and improve patient outcomes and patient safety. Is really the goal of a lot of these simulation-based activities, just like flight simulators are for flight safety, so you're not taking, a pilot's not taking you up on their first flight. Likewise, we're going to simulate some of these activities so the patient doesn't have you train on them, but train on simulation.
All right, thank you, Dr. Yeah, exactly. Really, well, patient safety is what we are emphasizing as well, and teamwork. So the course of the Team Steps framework is composed of 4 skills, that of leadership, situation monitoring, mutual support, and communication. So something we have here is the rapid response team roles, and essentially it lists number of people and what their role is and what their responsibility is in that role. For example, we'll start with airway manager. The airway manager's role would be to obtain an airway and the airway equipment, assess and assist in ventilation, intubate if necessary, and check the pupils. The airway assistant would be assisting the airway manager in setting up the equipment and being there for the suction if needed to prevent any aspiration. Then you have a bedside assistant, which also checks the pulse, the vitals, and administers the medications. Then you have your circulation manager, which you perform chest compression and place the defibrillator pads if need be. Here you have the procedure MD, so they're obtain the IVs, chest tubes, and arterial blood gas and blood sugars. And another role would be the crash cart manager. So they record and prepare the drugs, and they operate the defibrillator and deploy all the equipment needed. The treatment leader would assess the team's responsibilities and data, and direct treatment and set priorities. Then you have the data manager who records all interventions, and if you have optional other people available, you can have transport labs, which helps with the equipment setup as well. Okay, so if we're talking about leadership, you can have 2 types of leadership, that of a designated one or a situational one. In effective teams, any member of the team with the skills to best manage the situation can assume that leadership role. So an effective team leader would be able to organize the team, articulate clear goals, make decisions through collective input of members, and empower the members to speak up and challenge when appropriate. Additionally, they actively promote and facilitate good teamwork, and they skillfully resolve conflicts. These are what we think are great attributes of team leaders and what are expected of leadership. So if we're going to go through events, so pretty much you want to share the plan, right? This is assigning essential roles, establishing the expectations, and anticipating outcomes or contingencies. That's prior. And then you have a huddle where you're monitoring and modifying the plan. When problem solving is needed, huddles are used to reestablish the situation awareness and assess the need to possibly adjust the plan. And then following, you would have the debrief where you're reviewing the team's performance, which is designed to improve the team's performance and effectiveness via feedback from the team. We'll go into a situation monitoring, is the process of continually scanning and assessing what's going on around you to maintain situation awareness. So here we have a circle where it says situation monitoring individual skill, which leads into the situation awareness, individual outcome, and then the shared mental model, the team outcome, and it goes over and over. And a tool for monitoring the situations in the delivery of healthcare are the components, are the STEP. So status of the patient, team members, environment, and the progress toward our goal, our shared goal, actually. And here we'll talk situation awareness, is knowing what is going on around you and knowing the conditions that affect your work.
I'm just noticing some blank stares. There's a lot of big terms that maybe you haven't heard before. We're just labeling things that happen naturally in a team environment. It sometimes helps to think of it as a sports team. Maybe some of you have played or watched that they use And in that structure, everybody has their position, everybody has a captain, a coach, they practice together. When you're in the middle of the game, if you have the ball, you see who to pass it to, who's open, what's the situation around you. And it's really sort of a good analogy. Don't get bogged down in the terms. We're not testing you on that. We just want you to conceptualize that there is a structure for the team of healthcare and how we can work best together in practice. The coach, the captain, it's a similar analogy.
You got to think of a team as a machine. Everyone really needs to do their own role in order for the machine to work effectively. And sometimes it helps to only focus on your task at hand and let everyone else do their job, which can reduce the errors going forward. So here we have some examples of poor situational awareness, right? No one should be taking a selfie at a funeral or taking a pic with a shark right behind you, right? Who knows if this guy's still alive? We don't know. But you want to be aware of what's around you and make sure you're making those decisions based off that. So if we're talking about situation monitoring, we have shared mental models, which result from each team member maintaining his or her situation awareness and sharing relevant facts with the entire team. This helps to ensure that everyone on the team is on the same page. And then you have your cross-monitoring, which is used to reduce errors, and a strategy that involves monitoring the actions of each other's team members. So you provide a safety net within the team, and you ensure mistakes or oversights are caught quickly and easily. So you really essentially are watching each other's back. If you see something, you say something. It's really important to provide that mutual support. The task assistance is one form of mutual support in which team members protect each other from work overload situations, place all offers and requests for assistance in the context of patient safety, and foster a climate where it is expected that the assistance will be actively sought and offered. Here we're going to transition into the communication aspect and how to identify, for those who aren't familiar with IceBark is, and go about the effective communication. So,
good afternoon, everybody. 27 to 30% of medical malpractice is a result of communication. It can be in whatever form. It can be lack of communication, no communication, or miscommunication. So you as healthcare providers, it is so important that you maintain communication, because this is the key in order to get that outcome that we want, that positive outcome. So we are going to be talking about ISBARQ, or is SBAR for us nursing students, but I think it's all updated with ISBARQ. So we want to make sure that you are familiar what this is all about and what are your roles when we talk about ISBARQ. The first one is identify. Every time you call your doctor or you call somebody who is part of the healthcare team, make sure you identify yourself, okay? Example, if you're calling Dr. Roberto Gutierrez, you call, hello, Dr. Roberto Gutierrez, this is Sharon Rodriguez. I am the nurse of your patient. Let's say Isabel Cortez, who is in ICU, bed 5. Okay, identify yourself because it's very important so the doctor will know who you are and who you're calling for and what unit you're calling from. Then the next one is going to be your situation. Why are you calling the doctor? What's going on with your patient? Does your patient have shortness of breath? Did your patient complain of chest pain? Maybe now your heart rate is going to 150 beats per minute. So you need to know what's going on. Well, doctor, my patient, Ms. Cortez, now has a heart rate of 150. She's complaining of chest pain. And this is a patient that was admitted yesterday because of substernal chest pain, and we are ruling out MI. But all of her troponins were negative. So at least know what's going on. So that will be your background. Let the doctor know what's going on with your patient and provide him with all of the information that he needs so that he could make that decision, right? And also make sure you know your assessment. You're giving him a situation, but now what is your assessment? What have you found out of the patient that will quantify what you're telling your doctor? What's the vital signs of your patient? What's the mentation? What about his consciousness? Is there a change from the previous These are things that you need to communicate with your doctor so that he will know what kind of intervention he is going to give. Recommendation. Can you recommend as new physicians or as nurses to your doctors what you want them to do? What do you guys think? Can you? What if your doctor says, who are you? What do you think? Are you going to expect that kind of communication? Usually not, right? Because everything is in collaboration. We as nurses, usually we are there 24/7, right? And our doctors are not there 24/7. So we are usually the advocates of the patient. So we want to make sure that we are going to what? Advocate for that patient. So you can recommend, doctor, I know that her troponin levels were negative. Maybe we should now get a set of troponins. I think the patient has having an MI. The EKG now shows that there's S elevation. Let the doctor know what's going on that is relevant to your patient. Let them know what is the history. Let them know if there was any change in medication. Let them know what is going on with your patient. Because, as I mentioned, you are the person who could let the doctor know what's going on at that very moment. So when you get that orders, you know that it does make sense, okay? So please make your recommendation and then ask the doctor, doctor, what do you want me to do? Okay? That's a question that you have to always ask also. So when he gives you those orders, also make sure that it makes sense, okay? You can question the doctor. It's not just because he gave that order that yes, doctor, yes, doctor, yes, doctor. Okay? We are not trained just to what? Carry out orders or to follow what the doctor says. We are educated enough to also make suggestions and question the doctor's orders, right? Everybody, right? Because we are all there for a positive outcome for our patients. So question the doctor, okay? So a lot of this depends on the individual who is communicating to the doctor. If there is anything relevant that you know that will help that patient, please speak up. Please let that individual know that this is something that you are thinking about so that it can also be taken into consideration. Okay? So, why is ISBARQ very important? Because it's a tool. When there is a tool, use it because everything is very critical. Everything you're going to mention to your doctor has a point. You need to know what has my assessment do to the orders my doctor is going to give. Once you have that experience, you guys are going to just what? Come up with all of those recommendations because now you could tie in everything together. You're now going to know what the doctor is going to order because this is something that has been done over and over and over. But please continue to use this kind of a tool because you will not miss anything if you continue using this kind of communication. Okay? So let's go to the next. Communication says using cuss word is one way to stop the line and alert other team members to your concerns. Cuss word, and this is not cursing, okay? Remember that. You as healthcare provider, you need to always speak up. Always say, I am concerned. If you see something that's not going right, follow that gut feeling. If there's something in you that is saying, oh, this is not right, speak up. Because that one time that you spoke up may have saved that life of the patient. Or if you did not say anything, might have caused the death of that patient. So speak up. There's no harm in speaking up. Then we'll take into consideration what you have said. I am uncomfortable. If you said a concern, let them know what's concerning you. Doctor, you know what? I'm concerned with the heart rate of Miss Cortez. It was, at the beginning, she came in with 75. Now it's going at 150. And I'm really uncomfortable to let her go to CT scan at this moment. Okay? Say something. Then, this is a safety issue. I'm not comfortable of sending her to CT scan because you know if a heart rate of 150 continues, what's going to happen? She's going to collapse. There's not going to be any oxygenation or perfusion, and she's going to what? Maybe code on you. So speak up, and you know that it is not safe. Okay? So always practice this. That's the reason also why the Joint Commission put together the Universal Protocol. We need to make sure that you know when to what? Time out. in any procedure, make sure that you have a timeout, whether at the bedside and even more importantly in the operating room, right? If you are going to start that, okay, before even starting, you need to identify that patient, identify what type of surgery, identify the consent was signed, identify the prep was done, identify allergies. And if one person says, I am uncomfortable, I have a concern, everything stops, okay? Everybody in that OR room has to be a participant. But if somebody says, I am uncomfortable, then everybody has to stop and listen and go over it again. Because I said communication is very important. And if we miss one detail, that can be the life of that individual. Here are just some examples, okay, that you could read over here. We're not going to go over it. But that communication is key to a positive outcome of your patient. Okay. So there are two challenge rules. Like I mentioned earlier, at the very beginning, when you have a concern, when you're uncomfortable and you know that it is a safety issue, speak up. If they're not going to listen, speak up more, okay? Meaning to say, let's now go to the proper channel. Don't be part of that, because if there is going to be a lawsuit, you were also part of it. You are an accessory to the what? To whatever happened, okay? So make sure that you make your voice be heard. If you're not comfortable right now speaking up for yourself, this is the time to do it. Because you will be in situations in the hospital that you are going to be on your own at that very moment until you call your charge nurse or your rapid response team. But before you do activate them, make sure you do your independent role, right? So once you recognize that, okay, I really need help, don't wait until your patient deteriorates. Call for help right away. You need to recognize that also. Okay? So, anything else, or am I done? Okay, so there are other tools. Okay, one of them is call out, as we mentioned, like in the universal protocol, and also check backs. If you get any orders from your doctor, let's say you're working in an ER and ICU, and all of a sudden you have an emergency. Okay, the doctor will give you some verbal orders. You as a nurse, make sure that you're going to verify this order by what? Saying it back. Let's say, for example, the doctor ordered Demerol 15 milligrams IM to a 60-year-old female because she came with a broken hip. Let's say, for example. So if he gave that as a verbal order, and I know in the ER it's so, very busy that doctor cannot just write that order. So he is going to let you know if you were like assessing the patient. So you're going to say, doctor, you ordered Demerol 50 milligrams IM times 1 now, and he said yes, then go ahead, prepare it. Then you go to the chart and remind him, okay, that he documents that. If you're still doing paper charting, you document that, okay, and you put verbal order, read back, doctor's name, and your initial, okay? And never give any medication that you did not prepare also, okay? So that's one thing that you need to remember. Always close that loop. When in doubt, when you are not sure of that medication or that order that you got, always clarify and verify. Important, okay? Because again, just that one minute 0.0001 can cost a life. So communication is important. So medical MDs and future nurses, please make sure that you maintain that communication. Whoever you're communicating with, always remember there's a life at stake. Okay? So, okay. Awesome. Thank you.
Thank you. So just to really talk about what a SOAP note is, right? So SOAP notes are used to document a patient's status and are typically written once a day. They're primarily used by physicians to communicate with each other, and unlike H&Ps, which are extensive and gathered at admission, SOAP notes are meant to relay only pertinent information and are kept relatively short. So the acronym is subjective. So subjective are things the patient tells you. It's in their own words and is used to assess if the patient is improving, or if any new medical issues arise that need to be addressed. O is objective. It's what you are objectively looking at from your patient, the general assessment, vitals, physical exam, labs, images. Then you have your assessment. You gather all that information and you create diagnoses that are being considered and managed. And then you create a plan, which are diagnostic and therapeutic, and interventions underway to address the patient's status. Yes.
So, how many nursing students have heard the term stroke nurse? Yes. How many medical students have heard ISBAR? So it is, these are the two tools that these two professionals use to communicate with each other and with the rest of the team. But when one side doesn't know how the other side communicates, it creates a barrier, right? This is the term assessment. Assessment in the ISBAR is really like the objective in the SOAP, right? The assessment for the SOAP is the physician's differential diagnoses and what they're thinking might be happening with the patient in terms of the condition related to their H&P and their admission, if it is, or an outpatient visit. And so it's important for both sides to understand that language and not to misunderstand what assessment means or to expect the order in which the information is going to be presented. This is typically how doctors talk to each other sometimes when they're signing or talking about a patient in this order or presenting their patient. So just knowing what tools each other side of the teams use is one way to reduce the miscommunication. Okay?
All right. So we're gonna play this video, which you guys should all be paying attention to. Hopefully it plays. Can you guys see this? So if you guys have seen this, try not to share with your peers. If you haven't seen it, try paying attention.
Yeah. Count how many times the ball is being passed.
Sorry about that, guys. Try to do that one more time. Hold on. You kind of went through. I don't know how to fast forward.
It's done anyway.
So if you did find something, see if there's anything else you may have missed
How
next
many
time.
times?
Situational awareness.
Let's go to the gorilla. Anybody?
You guys saw the gorilla? So about half missed the gorilla. If you knew about the gorilla, you probably saw it, but did you notice that the curtain changed color? Or that the player in the black team leaving the game? Right? So let's rewind and watch it again. Even though we already did, but we're going to do it again. See, she left in the back, changed color.
So when you're so focused on one aspect of the task, you can lose your situational awareness, which may be crucial for the outcome.
Alright, so that was a little fun video. So this is inattentional blindness, is a phenomenon not being able to perceive things that are in plain sight. Can result from having no internal frame of reference or having a mental focus or attention that causes mental distractions. Alright, so here we're going to be in teams. We're going to have one MD student and one nursing student in one case, and then in case two we're going to have four MD student, four students, and four nursing students. So for scenario A, we'll have one medical student and one nursing student. If you guys want to volunteer,
Alright, so for Chamberlain, who from our 5 wants to go first?
You want volunteer for
I know we have 5
This is a case covering the ethics objectives and the objectives of palliative care, which is hospice, which is treatment, just to give you some context.
Yeah, well, it's not here. Are we doing here? No, it's, yeah. You're gonna be seeing them,
Participate, focus on your patient and the task. The ones here, try to connect everything that we just discussed with what you see happening.
What supplies do I need? Are you on Dahmer?
You have them all.
Okay, good.
Haven't been discussed.
I haven't been told,
And
but
here.
I have that.
I'm gonna do it.
Oh, wait, you're going outside? I don't know. Just follow John will guide you. So are you going to?
Yeah, what's your role?
What was it? Slab? Are you talking about it? Are you talking about it?
No, I believe you still are, so.
I thought I might be able to get out of it. We going now? I think we do.
Nobody said it. Oh, okay.
Anything you need on my part? Anything you need right now on my part? Got some quick email to send back to the office.
Just make sure that somebody's watching this.
What is background noise?
Hmm?
You can hear conversation in the background.
No, that was something.
There was something like that? Okay.
Are you going in?
Hey.
Just saying to right here. This is last time. I don't know.
For you?
So, patient 6.
Oh, I'm with history. You argue with me. For your wedding or something.
Got it. Do you want this right here?
No, I'm good.
Are you sure?
Yeah.
Do you want me to bring your blanket?
No, I'm good.
I don't do this at all. It's been really busy.
Yeah. Where have you been?
Interviews,
Mm.
tired.
Mm-hmm. Where have you gone for interviews?
Michigan. Yeah, what are you crazy? No, no, so I want to be close to you.
Okay. Okay.
Okay.
Okay. Cool.
The more I get from them, the better.
Mm-hmm. Guess it'll just get a lot colder. Close, that's all.
Yeah, no, I like it. I actually like the change of environment. It's
Oh, I do love the change of
Yeah.
As long as you're prepared for it, isn't it? You know.
The only time it will be difficult is when you're not prepared.
Mm-hmm.
You're not expecting the cold.
Yeah, if you go there and Florida close, yeah.
Yeah.
Mr. or Mrs. Jones? Because mine says Mr. and Mrs. Jones, I think.
I'll just go with like, whatever.
Yeah.
Whatever you like to call me.
That soap dispenser looks like it's a spitting cat. Because you look at the soap dispenser,
Oh,
the circle
yeah.
in the back, looks like it's a hidden camera.
Oh, yeah,
It's
you're
not,
right.
it's just the way it's set up.
I had to make sure. I'm like the spy on actually do watch us.
I was gonna say, they watch all of us.
Yeah. Why this one? No. Why this one?
Because they're trying to take this to show it
Are you serious? Okay, gotta get my acting straight. Take this off and everything.
What's a little extra?
It's just a reminder for life.
Okay.
When I was younger, I wanted to not forget something really nice.
Oh, yeah.
I just have to, so I never forget. Yeah.
We did when I was younger, it was like rebellion.
So he's been partially thought he knows he's gonna come in here and speak with you and address your concerns and eventually speak with the physician and we'll have the physician
Right.
come over here and
Right.
speak with you. So make sure I have enough chairs for when everybody's in here. I don't have the walkie-talkie, but I'll go back over and see if they're ready to start.
Okay.
Is there a hand sanitizer?
Right here.
There's hand sanitizer.
The hand
It's
soap
just
is
over
dead,
there.
but,
Do you wanna put it over there?
just put it over there,
Yeah,
it's
so
easier.
that way when I walk in,
Mhm.
you know. I wasn't nervous, but now I am.
Why?
Stop it.
I know. I don't know.
The worst that can happen.
You're not giving any medication.
Yeah, I know, right?
This is more communication.
Hi there. So we're trying to do a sound check. I want to text you, and you could say testing or hello.
Oh, we should say, you gonna say that?
Yes. So just you have your WhatsApp on you?
Yes.
Okay. So I'll give you a heads up.
Okay. Oh, he said he's doing a sound check.
Okay.
It's really cold in here.
Mm-hmm. Check out the doctor's office.
Yeah. Seriously, why do I always have to make doctors
I
so
don't know.
uncomfortable?
I thought ORs were bad. They were always cold.
My office will look like a home. When patients come in, they feel like,
Mm-hmm.
you can feel like comfortable. I don't make it feel in the office.
People say that about my office. They have me fancy. The only thing I wish was a little bit bigger to have a chair with a pillow on.
Yeah.
But it's not that big. You see my office, it's tiny. But I have a lot of my personal things. So. Actually, I think my students gave me nurses. You know, bear nurse or, you know,
Really?
little statues and stuff.
That's so cute.
It's, like I said, I just wish it was a little bigger for me to put a comfy chair in with a pillow. That way you can feel this comfortable.
They're doing sound check now. Hello?
Hello?
Hi.
Hello? Hello?
Let's talk. I guess this will be the sound that we'll have right now. Like,
Yeah.
okay. I don't know if they can hear us. Can you hear us, Dr. Nico? Hi.
No, they can't hear us.
They can't?
No.
Let's talk a little louder. Let's talk a louder. We're talking louder. How about now?
Hello.
Hello? Oh,
We're
you're
talking a
off the
little
mic.
louder. Hi, Dr. Nieko.
Hello. Testing.
Testing, testing. Hi. Hi, Dr. Nieko. Hello, hello.
Are we shouting?
Yeah, I'm not gonna shout. Yeah.
Hello, hello. Testing, testing. Dr. Nieko. Hi.
Let's try again.
Yeah.
You used to work in an OR, Professor Conti?
I mainly did oncology nursing. For a short time, I went to OR to do PACU. Then our hospital opened up the outpatient center and I went there instead. Outpatient oncology.
I work in a PACU now as
Doing what?
as a patient care tech, CNA. We're
They
like,
let you PACU? They let CNAs? We never had CNAs in PACU.
we do the labs, we're the transporters,
Okay,
we do
yeah,
like
oh, you do the transportation and everything then.
half the labs. Well, like when the patient comes out, we'll help put them on feeds, do a temp, you know,
Mm-hmm.
or phase 2, get them ready to go home.
Wow,
Yeah, we have.
because with the RN role being the assessment, we never let CNAs do that.
We do.
Now,
we
to
do
be a
like-
runner or stuff, you know, for the labs and stuff,
Yeah.
maybe, but we wouldn't, because the assessment was dependent on what I believe, you know.
Oh, yeah, yeah.
Yeah, but then we hooked them up to the machinery right away, so they can.
Testing,
We just help.
testing.
We
Sorry.
just help a
Hello.
lot,
Try again.
basically.
Hi, hello.
Hi, guys.
Hello.
You guys are talking anyway, so they should hear us.
Yeah.
Just try again. I don't think they can hear us.
I don't think so.
Dr.
They need to
Nieko,
come here and
hello.
adjust their equipment. But, because with PACU, either pre or post, it was so important that we had an accurate assessment. And
Oh,
we can
yeah.
do with,
No,
you know.
for sure. We're just kind of there as extra hands.
Oh, that's cool.
This is
That's
such a
cool.
weird camera. It's really, really weird.
It's really tiny too.
I
Guess
thought
that's
that
the
was
goat.
the microphone. I guess
Huh?
not.
No, it's this one here on that pole.
Hello, testing, testing.
No, but we definitely could have used some CNA for the transport and stuff. Because when we had to call for transporters to come down and help us bring the patient to the room.
Okay, they can hear us.
Yeah,
Great.
and stuff, okay. Good. So, we love to put our hands, especially when we had all the tubes and everything. We had to take an ICU, I took them to
You can hear everything? Okay, great.
Maybe you should have a chart in your hand? Might help? Yeah. Just tell me about something. Yours is? Oh, yeah, I think so. Yeah, I think your wedding is coming up or something, and I don't want to be around there, so. Yeah. Because you're really looking at me,
Hello.
Hello,
good
how are
afternoon.
you?
I'm
Hi.
good. Hi, I'm Jonathan. I'm one of the nurses here in the office.
Hi, Jonathan.
Jonathan, how are you?
I'm good. How are you doing today?
Good.
What brings you to the office today?
Well, I was supposed to discuss with the doctor about my treatment plan.
Okay. And what kind of concerns or what is it that you wanted to discuss? Or is there anything I could
I
answer?
really want to tell the doctor I don't want treatment.
You don't want treatment?
Well, not really. So we really just want to talk to the doctor. I want the doctor to convince her to, continue with the treatment, or if there are other options for us to consider, because she can't give up right now. Like, this is not the time to give up, and I really want to talk about that.
And I want to talk to the doctor to tell her to leave me alone.
Wait, that's not gonna happen, Mom, that's not gonna happen, so.
You can see that there's a little conflict, and hopefully we can come to a, compromise. And I'll definitely bring your concerns to the doctor, and, we'll go from there. Is there anything that I can answer for you guys, or anything?
Well,
Well, we were talking about hospice versus palliative, and, can you tell us like the difference, like what would
So,
be?
so the goal of palliative is more to bring comfort to a patient when kind of treatment is no longer an option or not wanted. Hospice is more about when a patient is expected, the life expectancy is like 6 months or less. They're
Okay,
both, but the goal is both the same with both. It's just how to keep the patient comfortable, not
that's
really.
not what I read on the computer.
No? What
I
did you
was
see on
told
the computer?
palliative care was more, you could still have your treatment, just to make sure that I have proper management of all the pain and side effects
Right.
and stuff.
And
Yes.
keeping comfortable, and your pain is a big thing, managing that.
Mhm.
And hospice is more of like the time setting.
okay, so well, I guess that's where I want her to continue treatment and also be comfortable.
I've had treatment before,
What about alternative stuff? We can consider that. Maybe we can talk to the doctor about anything else.
See what he
that's
knows
new.
about alternative.
Yeah, I mean, it might be different medications or, so
I've
this
read
is our
some
life.
macrobiotic diets and all this stuff, and I'm like, yeah, they ain't happening.
Oh my goodness.
Well, it's, it depends on the person, and we can, build something individualized for her. We'll see. I'll
Yeah.
bring your concerns to the doctor, so let me go talk to
Okay.
Dr. Aaron.
Okay, thank you, John.
Thank you.
And there's a counselor school. And we can answer too. But him and the dad. She probably just says she has some. And then we're talking about this. So how much longer before you start? Summer? Wow. Okay, that's what you mean. When will you get a note, like saying that you made it or not? March. Then they all go out, right? Yeah. Mm-hmm. To find a place to live and everything. Yes, vacation. Yes, good. Sometime I haven't had a vacation in 6 years. I was gonna say, it's been a long time. It's been a while. Well, I've had little vacations here and there, but always like stress. I have to study, I have to discipline, residency. So you've done all your exams? There's like one license exam left, but that's, if you do have to do residency, but I want to do it now. So I will probably study for it after March. And they pay you for your residency? Yeah. But it depends on like, I know. There's like kind of my tuition and everything. Just keep me alive. Basically just a teacher. Yeah. Yes? Hello.
Hi, Mrs. Conti.
Hi, how are you?
I'm Dr. N. How are you doing?
I'm doing fine.
Yeah, you're feeling good?
Hands are ice cold.
I'm so sorry. It's genetic. My grandmother has cold hands. I'm so sorry.
Warm heart, that's okay.
Yeah, okay.
We'll go.
So what's going on? How are you
Well,
guys?
I know we were talking last visit that my cancer came back,
Okay.
and you gave me some treatment options, but I've decided not to have any treatment.
Okay. And you don't want treatment? Okay.
But
is there
we
any
really
issues
want to,
with that?
yeah, I think I came just to make sure that we discuss other alternatives.
Okay.
I think it's too early for her to give up right now.
Mm-hmm.
I have a wedding next year and she has to be there, so
Okay.
I don't understand why she's like being so stubborn.
Because I've had this treatment.
Okay,
And
but
then you visited me in ICU. I don't want to.
I remember that and I don't want that for you
You were
either.
young, you were young.
Okay.
We're gonna go through that again.
Okay, I mean, I completely understand where you're coming from, because you would want your mom to be at your wedding,
Yes,
and I
yes.
understand that, but, Mrs. Conti, she's able to make a decision on if she wants treatment or not, depending on how she's feeling about the treatment. We're gonna try to work with both of you, so you guys are both okay with moving forward, but ultimately, the decision is Mrs. Conti's to make.
Yes, but I think it's your job to let her know about, you know, the different options that she's available.
The treatment they're talking about is gonna make me sicker than the first time.
Okay.
Is
I
that
don't wanna
true?
do
Like,
that.
is there anything else we can use?
Okay, well, the treatment, well, that I did discuss with you, Mrs.
I mean,
Conti,
that's
will
kind
make
of
you
heavy
sick.
duty. I looked it up on the computer. It's
Okay.
very heavy duty treatment. I was in the ICU last time with no white count, almost dying. I don't think I don't
We
wanna
can
do
definitely
that
look
again.
into, other options, I can do some research and look into other options, and maybe we can discuss that and see if that would be something you would be interested in, Mrs.
But
Conti.
we were trying to ask the nurse, what's the difference between palliative care? I know what hospice is. Hospice, friends of mine have been on hospice and died 2-3 days later.
Okay.
What's palliative care?
Well,
What does that include?
well, it's just a way to make you comfortable, and kind of remove pain from your sensory abilities while you're going through this period of treatment or in the stage of the disease that you're in. We just kind of want to keep you comfortable and so that you're not
So
in
your
pain.
palliative care doesn't do anything for my cancer?
It's not aimed towards a cure, it's more just comfort measures.
Yes,
So generally the end.
Right.
Okay, well, I'm not taking her to her deathbed, is that what you're saying? Like, yeah, I'm not doing that.
So we don't want to give up on you, Mrs. Conti. But if you feel like
I've had friends of mine that have had cancer. They're 10 years and they still have cancer.
okay.
The treatments that they're getting, they're able to live with. They're not these chemotherapy treatments that they're vomiting their heads off and doing that. Their cancer hasn't gone away, but they've been alive for years with this.
Okay.
So what's the difference? And why can't I have something like that? Why do I have to have such aggressive treatment that's going to make me so sick that I may not make it to her wedding anyway because of it?
Well, Mrs. Conti, your cancer is a little bit more aggressive. That's why the treatment is so aggressive. In order to try to target the cancer cells and get rid of them. That's the only reason why it's so aggressive. We can try to look into other options, maybe decreasing the dosage. I'm not sure. I would have to go look into that and give you a better response and on changing the course of treatment, so you can make that decision when you see all options that are given to you. We can look into that.
What about alternative, like anything not chemotherapy? Can we like try anything else that will make her feel better?
Well, not with her type of cancer. There's not any alternative treatments that will fight the cancer, but we can make you comfortable and take away the pain, maybe give you pain meds.
Is there anything just to stop the cancer from growing and just, kind of leave it there?
Not right now, but research might come up with something better. But at this moment, what we do have to fight your cancer will have side effects, and it might make you sick. You might not feel good.
I mean, I know a friend of mine who has breast cancer. She was told it was very aggressive, but she's living more than 5 years with it.
Well, everybody responds.
She's not getting chemotherapy right now.
Right.
Everybody responds differently to treatment, so it's very individualized and it depends on the person. So really, it's ultimately, right, doctor, her decision.
Yes.
Is there anybody else I can consult on what new treatments are out there?
I can give you some information on other doctors who do more natural remedies. If you wanted to look into something like that, I can look into what may be out there and maybe suggest something to you, and then that would be ultimately still your decision to make to get out of the treatment that we have right now and go into that.
In respect of my daughter, I don't mind the treatment, but if the treatment's going to make me sicker than I feel right now, it's not worth it to me. And like I said, I go to a support group. There's other people there with cancer. they're on treatments. No, is their cancer gone? No, it's never gonna be gone. But they're living a normal, somewhat normal life.
Yeah.
You know, they're enjoying their grandkids, they're doing those kind of things, which I would love to do.
Yeah, and I want her to see my
But
kids.
I also don't wanna be back in ICU with no white count, fever's extremely high, tubes coming out of everywhere. That's not life for me. And I'm not gonna do that again.
Okay, I totally understand, and I would want you to see your kids too. Maybe we can look into palliative care. I can maybe give you some brochures so you can read up on it and see exactly what it's about. And if that's something that you're okay with, then maybe that's an option that we can explore.
Or I'd like a choice of options, you know, I'd like to see, you know, some type of a menu of like, okay, choose one from A and one from B, one, you know, not that it's a Chinese buffet, but I just feel like this is the only option you've given me.
Okay.
I know I'm not gonna do it,
Okay.
but I also, like my daughter says, I'd like to be there for her wedding. I'd like to be there when she has a baby. But I also know that I'm not gonna have my kids, my grandkids, or whomever, watch me in an ICU with tubes coming out of everywhere for no reason, because it's not gonna get any better.
Okay, that's understandable.
I
So
mean, I've had this cancer for a long time anyway.
okay, so I can give you a few options on what is out there for that kind of care and long term. So you can see what is out there, and we can discuss it after you've read it, what you think you would want to do. We can kind of find a good fit for you if that's truly what you would like to do.
I'd like to do something more like that.
Okay. Okay.
Because I went through the aggressive treatment. I did it once. I gave it its chance.
Yeah.
And now here we are back here again.
You know, it's really difficult. So I understand completely where you're coming from. So I will definitely look into that. I will go get some brochures for you. Maybe
And I'll
Jonathan
with
can
that.
help
I can go over all
grab
that
some
stuff with you.
brochures so we can
Mhm.
you can take a look at those.
Okay.
All right.
I'd like to have some options, and then we can discuss it with everybody in the family.
Yeah. Okay. Yeah, we can give you some before you leave today. We'll give you some brochures. Outside of that, is there anything else that you guys would like to talk to me about? Okay. When is your wedding?
It's next year, so, you know, you can tell my frustration that she's refusing this right now, and,
Well,
she's-
we'll-
You can take my picture there, it's
okay, well,
Bring
she's
my
being
picture.
stubborn, she's being very stubborn, and it's upsetting.
I know, I can imagine.
How
But we'll
upsetting
find
was it when
something.
you saw me in the ICU?
It was very upsetting, but
Okay.
it's,
Well, I think we're past that now, and I'm
Yeah.
glad we broke some ground here, and we're going to more of the options, right?
Yeah.
That's a positive.
Right, yes, that is positive. Thank you, Jonathan. That's very positive. We'll find the best fit for the whole family, and
Okay.
hopefully everyone will be good.
Yeah.
You especially. Yeah. Okay?
Yeah.
Thank you guys for coming
Appreciate that.
in.
Yeah.
Thank you.
Thank
Have a
you
good
for saying
day.
that. Thank you, Ron.
Let's go get that stuff. for
Yeah,
them
let's, yeah.
Before you
grab it.
guys leave.
Should we
Yeah,
like
we'll-
stay here?
Yeah,
or-
just be right here and Jonathan will bring it back in for you.
Okay, alright, sounds good.
Okay,
Oh.
thank you.
I'll go get that.
Sorry
for you
about it
guys.
anyway. We done?
Good.
Okay, Lou, talk to me. I thought palliative care was to kind of keep everything under control, because he kept going down. Are we off now?
And our patients?
So, what do you guys think? How they did and what is yeah? What about the student? How did they felt? John? Yes, please. What do you think?
I was a little nervous, but it went well.
What was the difficult, challenging questions? What was the
The conflict between the patient and the daughter, that, you know, the patient didn't want treatment, daughter wanted it, so there was a big conflict with that.
pretty normal? You're going to see quite a lot of them throughout your career. Wherever you are in ICU or oncology floor.
That was mild. Let me tell you. That was mild. I see some that are, we had actually.
So, yeah, you'll see them. What about you? What do you think?
I think I had difficulty with giving her information about alternatives. That was my struggle. As far as the conflict between them, it was kind of like, you guys are family, so I'll let you handle that, but I'm gonna give you, in my head at least, this is what I was thinking. I didn't have information to give her on alternatives. I didn't know.
Sure.
So that was my.
And that's fine.
Yeah.
And there's nothing to say, well, I'll call, I'll research it for you, and the next visit you come in, I'll have some options for you, or I'll contact NIH, or I'll contact the Cancer Society. Those kinds of things, nothing wrong with that, because you're not gonna have everything at your fingertips.
Right.
We would love it if you did, if you were that kind of person, but that's not their life.
Okay.
Okay, so there was nothing wrong with that. Because you did say, well, I'll look into that, but what you talking about?
So the real tension is really what patient wants sometimes and what is a healthcare wants, professional, or the family wants, right? That's the tension. But in our Western ethical principle, usually always what supersedes is
Patient.
what? Patient what?
What?
What they want, or autonomy, right? In Western principle, between beneficence or a best interest versus what patient wants. If a patient have a sound mind and a decision-making capacity, it supersedes almost everything, right? Let me put it this way. So if you patient have a sound mind and a decision-making capacity, right? I didn't say competency. I said decision-making capacity. That patient have all the rights, and the family member usually can push it, but you cannot. Now, that varies from culture to culture, and you will see that across the country, because we are a very pluralistic, multicultural society, and you will see that, and you have to respect that, but at the same time, at the end of the day, your role is to bring the family and the patient to make some sort of a combined decision, right? Now, legally or ethically in our country, we have a couple of things we have put it together for last 25, 30 years. And you're going to hear those words again and again. The first one is called advance directive. How many of you have heard the word advance directive? Right? Quite a lot of you. What is it? What is advance directive means to you? Anybody can explain it briefly.
It's a paper, it's a document that shows like what you want if you were to come to the end of your life, or who you want to make the decisions.
So it's not really end of life. So let me put this together to simplistic way, right? So in 1970, we have a classical few landmark cases about end of life issue in a very young people, right? From 1970, there was a case called Karen Quinlan in New Jersey. Then there was Nancy Cruz, and young women died of car accident and with a permanent. If you're ever interested in ethics, you should go and Google and look at it. It's interesting cases. That leads to a government, U.S. Congress, in 1992 passed a law, because there was so much discussion all the way to Supreme Court that who will make a decision when a patient can't make a decision, whether it's a family member, or it's a doctor, or it's a court. What they come out is called Advance Directive in 1992. It's a federal law that every hospital in the United States any patient walk in the hospital, they should ask the patient and say, hey, if situation comes up where you can't make a decision, who will make a decision on your behalf? That simple it is. That's advance directive. In 1992, the advance directive was, if you can't make a decision, who will make a decision on your behalf? Every hospital are required to document that on the chart. Whether you bring a piece of paper, that's good. That's also, and I'll explain what that piece of paper, but that's standard and every patient needs to do that, right? And that saves a lot of time because many times there are family members are there. The who is in a family member, you have a 10 son and daughter shows up and they are fighting on themselves, they not talk to each other, everyone wants to help the mom, somebody wants some mom's money, somebody wants something else. It happens, you will see that again and again, and you get so confused as a healthcare professional. So that's advanced directive. Moving forward from 1992, another 5-6 years, people realized that, a lot of situation is related to the end of life, where patients said, there is a no, when I can't make a decision, or I am permanently unconscious, or I have terminal illness, right? There are two situations. If I'm permanently unconscious, or I am terminally ill, this is what I want, and that's another word came in next 5 years called living will. Have you heard the word living will? Right? So advanced directive and living will in last 20 years have now combined, and you see the document. Every state allow, or you can have, or each one of you can fill up, and that you don't even need a lawyer. Anybody can fill up and sign it and get it and make sure to give it to your primary doctor or carry it with you and bring it to the hospital. Advanced directive and living will. So living will say, if I'm permanently unconscious or I have a terminal illness, doctor, I want to tell you about these 5 things or 6 things. And the common 5 things are like this. Do I want a cardiopulmonary resuscitation? Yes or no? Do I want antibiotics? Yes or no? Do I want a tube feeding? Yes or no? Do I need a blood transfusion? Yes or no? Do I need an artificial feeding or a total parental nutrition or a J tube or a G tube? Those are standard questions, and a patient say yes or no. Even at the end, patient can say, oh, even though I've said this yes or no, but even if you, here is my daughter, can make a decision. That's where sometimes those living will create a lot of conflict and a problem. Let's say that you have a living will like that, and suddenly she get unconscious, then daughter will, now suddenly she want to do whatever she want on a TV. And that happened. That's multiple times I have seen in my 20 years of career when I was a chair of ethics committee. Those are the common standard problem, conflict. So somebody in a family have a different thinking. The health professional team have a different thinking. So you will see advanced directive and a living will. For you, most of the time, you have that advanced directive living will, the doctor and us look at it, document on the chart. Does it have you translate that information in a patient order? That was a still challenge for last 10 years. We have not having an easy way. Somebody need to recommendation from advanced directive living will need to put the order on the computer. Remember, that's just a document. If you're in a hospital, somebody has to carry out the order. So 5 years ago, maybe 7 years ago in the country, there is something else came up. So there is advanced directive AD, then is a living will, and now there are some states, I will say almost all the states have something called a POLST, P-O-L-S-T. You want to see, it's called a physician order of life-sustaining therapy, or is also called MOLST, M-O-L-S-T in some states. It's a medical order for life-sustaining therapy. Pretty much what it is a translating the document what you have in the real order. So if you're the paramedics or a EMT or a doctor can carry out that order, and you're going to see that again and again. Here is a simple way to think about it. When you have a conflict situation, when you can't resolve, you try to resolve, you have other option, right? First thing, you just have exactly what you did, right? Usually you get into the patient family, you either sit with the patient in solarium, find out all more detail about their life, and you want to ask a couple of questions. And you guys did it. Most of the time the question is really boils down to goals of care. What really patient want? What's the goal? She said, oh, I want to see my daughter delivering a baby. The question comes up, and I want to see my grandkids graduating from high school. Many times doctors will allow to give some therapy or chemotherapy if that's our ultimate goal of care. That's a discussion has to happen with the doctor and the nurses or health professional with the patient. And which is becoming a very standard. You need to decide the goals of care. So sometimes small amount of chemotherapy can help, and that's what it is. A lot of concern in a question, and you see the difference is really boils down to the quality of patient, quality of care, what patient sees for her own life, then us sees what is the quality of life or a quality of care, right? Quality of life. So she said, oh, I can't stand this nausea, vomiting. I don't care if your chemotherapy give me a 2 months. I just cannot want to have it. And you have to respect that as far as the patient said, that's what I want. Now, a lot of doctors, if you see again and again, they ignore it. They will say, okay, I'm going to give you chemotherapy. I'm going to give you 5 months. I'm going to give you 6 months. And that's pretty much true. There is a lot of tension you see. And a lot of time tension is not even between a patient and a doctor. The tension is between oncologists, the palliative care doctors, and the primary care doctor, the inpatient in charge of the doctor, a family member. And when you can't fix it many times, you have to just bring everybody together, right? You want to bring it together. The last thing patient want to see is that you do not have, the palliative care doctor, oncologists, and all do not have a consensus approach. Patients don't like it. And they don't trust you. You see again and again, they don't trust you. Same thing happen a lot of time in ICU. It's so common in ICU when patient is on a ventilator for a couple of months or a month. It look like patient is not going to do well, not going to recover. You have advanced reactive living will, and then every patient really, family member really think that every doctor, the cardiologist said, Terry's heart is good. Echo ejection fraction is 55%, very good. The dialysis nephrologist come and say, oh, creatinine is pretty well, very good. Dialysis is working. Pulmonary guys come and say, oh, the vent setting is very good. It's like you have an elephant and 7 blind people touching the different part of the elephant.
And they're only
Right?
concerned with that one little piece of that body.
That's right.
And that gets to be very, very scary because they miss the bigger picture of what's going on.
That's very common, we see that. And you as ICU attending, with the, most of the time it's nurses who really can see and then bring it together. I'm telling so many times on the floor, they play the major role in bringing the family and the patient together because you all spend a lot of time in the patient, right? I will advise you, if you ever get a chance, watch a movie or a Broadway show called WIT, WIT. Just go and watch that movie. It's a great movie to watch for everything about the patient's consent issue, 4th stage ovarian cancer dying, how the nurses help, how the doctors behave so badly. The doctor comes and gives a great movie. If you ever get a chance, watch a movie called WIT. Great movie, right? So that will help you. Yes?
I have a question. Would it be okay to speak with the daughter separate from the patient to say, I don't know, like, what get more.
So if a patient, go ahead.
But who's your major concern?
The patient, but like sort of explain that about what.
If you said that in front of me, I would think you were conspiring against me.
Okay.
Yeah.
That's
See what I'm saying? If you were doing that in front of me, if you turned around and said, well, let me talk to you outside. Excuse me. It's me, my life, Yes, I know my daughter's important, but I would think right away that you were conspiring against me.
I just thought it would help her more.
It might. I'm not saying it won't, but you got to be careful how you approach that.
But branching off of what she just said, sometimes like in STEP questions, we would have if the daughter or someone is concerned about like palliative care to just maybe not in that room in the situation. Could you just say to the daughter, why are you other than like the wedding, like what are your concerns about like the palliative care, and see if she can open up a little bit more and kind of redirect into, it could be a possibility that we do have to send her to hospice or palliative
Talk
care.
about palliative care because I think we're missing that little part about palliative care. Palliative care is for anybody with any disease. They don't have to be dying. Okay? Now cancer, we've changed the way we treat cancer. We've changed it to the fact that it is not
not, well, yes, we'll cure it, or no, we won't. And that's what I was trying to bring up when I kept saying, with my friends with 10 years of breast cancer, they still have the breast cancer. I think on the way, maybe it's being manipulated by hormones or mild chemotherapy from growing too fast. But we've gone from, okay, would you want somebody with arthritis to automatically go in hospice?
No.
Anybody with hypertension? Why do you want to suggest hospice for hypertension?
Only if it's terminal.
Yeah, we would just.
What is terminal?
6 months or less.
Okay, and you're right. If we believe that we think they're going to die in 6 months or less, then hospice is okay. Palliative care means they still get treatment. Maybe not the most aggressive treatment, maybe so, but it's to keep them quality of life. Palliative care is more quality of life.
Now, even this arbitrary 3 months and 6 months is really Medicare reimbursement and Medicare made up the rules, right? It's a payment. It's a 3 month, because you will see some people surviving on a hospice 3 months, 6 months, and then move out of the 6 months. But just to case in issues about family, that you will see sometime family member will come to you and say, you know, Dr. Rajput, I don't want my mom know about this diagnosis cancer. A lot of time you will see a grandma who is pretty sound mind, maybe she's not remembering few bingos numbers here and there, but she's reasonably good. And a family member said, in our culture, we don't want our grandpa or grandmother to know the diagnosis, because that will devastate it for her. And the most of the time, that's a very difficult, challenging situation you will come across. And my answer usually like this: okay, if you think it's mom you really don't want, let's you and I walk together in a patient room, and we let mom decide whether she want to hear it or not. I will not use word cancer. I will just say, Mom, she's saying that you don't want to know the diagnosis. Is that correct? If mom say, yeah, if she's telling you, I don't hear any diagnosis, I've heard enough thing, that's good enough for me, and I will document. But I will tell you, I haven't met any patient who is a sound mind who tell me I don't want to know.
I
Right?
haven't met any patient that didn't know what their diagnosis was either. And I was told many a time, don't tell.
Don't tell. So,
but they knew it.
but
exactly
be
what was
careful. You can't just say, yes, that's your own culture. As much I'm with all the cultural competency and respect every culture, but ultimately it's still the patient's life, and let the patient make it. And then patient says, I don't, it's the same informed consent. Some patient is going to tell you, I want to hear all the complication of this surgery. You like walk into the simple biopsy, and there are patients are so compulsive, obsessive, you found out from the Google 100, complication, they want to go through each one of them. And then you meet a patient who said, Dr. Ashwood, I know it's a biopsy. You tell a simple or common thing, and you say, okay, that's fine. So you're going to follow the way it is. So let me just briefly, so that's you're going to come across. If you have a conflict with you and family and a patient, and you think you can't handle, the next option is usually in hospital, it's called ethics consulting, who can guide you or help you. Occasionally the ethics committee and a risk management work together. Risk management is a legal team which represents the hospital and the ethics. You always get the ethics counsel, right? They can really help you and facilitate the communication between you and the rest of the team. You don't have to get all the time, but you will able to do that. Other thing you're going to see again and again, a lot of discussion is about withholding and withdrawing treatment, right? That's common in ICU. You come across ventilator withdrawal, withdrawal of dialysis, withdrawal of tube feeding. It is pretty common. There is no real difference between withholding and withdrawing ethically. Just we feel that if it's withholding treatment, many of us feel very comfortable, right? Like, I'm not going to give you dialysis, I'm not going to give it because it's not there. Most of us are going to feel comfortable. But if I need to withdraw from you something, if there is already a tube feed or there is already dialysis, and I'm going to stop it, your tube feed, the family flips out, the rest of the people flips out, you just get. So, but in the ethical and legal world, it's the same thing. Just keep that in mind. You're going to see quite a lot of tension in the ICU a lot of time is related to brain death issues, which is, I'm not going to talk about it, but keep it in mind. But there is one thing comes up, people are going to use this word very loosely while getting treatment, any treatment, and say, this treatment is useless or a futile care, right? You were going to use word and say, hey, this is futile, this is useless. Why this patient, 90-year-old grandma with a bed sore and nursing home in and out, revolving door for last 6 months, and the people will say the care is futile, or somebody is on a chemotherapy. Simple advice to you, do not word use futile in your documentation on a chart, right? Just avoid that. If you're going to use it word, then you really need to define what that futility means, and I don't teach you right now, it takes a long time, because there's a physiological futility, and there is a futility people think in the mind because of the quality of life. Because I'm the healthcare, I'm the nurse, and I see this patient suffering, and I think this is the quality of life is so poor that the care is futile. It's a very charged word you should not use in your care. But the simple is keep the communication intact between a family member and a patient. That's where you heard again and again, the things falls apart. And a lot of time the people get upset, the family get upset and get into the medical legal and they start threatening you only time because there is a break in communication. And these are sensitive communication. You cannot finish this communication in 5 minutes. If whenever I have a discussion in solarium, I make sure that my phone is down and I have at least 45 minutes, an hour to talk to the family. Just don't arrange ever a meeting with the family or anybody for say, 5 minutes, 10 minutes, right? It cannot happen on an instant message or Instagram. I'm serious. These require face-to-face communication in really physically. Occasionally, the family member is somewhere far off, and you want to get them in. But this is something which you need time. At the end of the day, it's all about how much they have a trust in you. The moment you have a trust with a doctor and a healthcare team, with a family, everything gets very easy. Once there is no trust, everything falls apart. Question, any question, or you heard something differently and said, Terry and Dr. Rajput, this is a little bit different. I used to hear a little bit different than what you're saying. Yes.
I just want to say it's true, like what you said, or what you said about, like, especially in the ICU, every specialist comes in and checks the heart or the kidney, but it's usually it's the nurse that communicates with the patient and the family, and it, like, tries to tell them what the point of care is and what the plan is for the day or for tomorrow. But there are a lot of miscommunication between doctors. So they just write their notes, but at the end of the day, it's the nurse that does a lot of the communication job in the ICU.
I had a really good friend of mine die, and it was very much a similar story. He had eye surgery. The eye doctor came in, eyes are fine. Heart doctor came in, heart's great. Kidney doctor came in, kidney's doing great. He's unconscious. What's going on? So a friend of mine called me and said, his wife called me at midnight and says, Terry, this is happening, but everybody says he's fine. So, unfortunately, I looked at my doctor a little bit and said, please tell the nurse to ask the doctor for the following. And I gave her a bunch of orders. He had total liver failure. And nobody caught it because everybody was so concerned about their little piece that they overlooked the big picture that was actually, and when the labs came back, we realized he was a liver failure at that point, and it wasn't due to alcohol, he wasn't a drinker, so it wasn't something that they had the history and could have maybe made that connection, okay, it was actually due to obesity, liver cirrhosis due to obesity, which at that time was a fairly new diagnosis, because that was not a recognized diagnosis at the time. And at that point, that's when the family stopped everything, But everybody was so concerned with their little world that somebody missed the big picture,
Yes.
So I've been in a situation where the doctor had to come in and answer family questions while my dad was getting surgery. And I remember feeling like the doctor was a bit nonchalant, like not caring about our questions, and he was kind of like, what do you want to do, Anthony? That's my dad's name. What do you want to do, Anthony? Like, no matter what questions we asked him, it was just kind of like, what do you want to do? At the end of the day, yeah, but what do you want to do? And to me and the rest of us, because we talked about it when he walked out, it was just kind of like, are you paying attention to what we're saying? Because we have legit concerns. Half of the family is like in the medical field, so we're asking questions, and you're just kind of like, well, yeah, but what do you want to do? And that's why I said what I said, because that's what I got from that doctor. And it was, in my head, it's like, okay, well, the family can figure out themselves, but what do you want to do, patient? So like, how do you balance like answering the daughter and making her feel like you're hearing me, and still letting the patient know this is your decision?
Absolutely, and that's sort of a art of the communication, right? You want to keep the family engaged and tell them what they want to know, but you want to be very careful and not making a decision what daughter wants rather than, so you have to bring the family to combine and make sure that they are with the patient, and that sometimes can be tricky. I've seen again and again, but yeah, you're absolutely
But
right.
actually, it made me feel that made me feel better, that you said, I understand, because you did, you went to the daughter and said, I understand what you're saying, but what does your mother, it has to go back, and opinion has to be a compromise. And that sometimes you have to let the family kind of work.
And there are a lot of times the family will come and say, oh, I'm telling you, you should listen to me rather than anybody else. And they will say, oh, she will be dead, but I will be alive. I have a patient have told me, Dr. Rajput, I will be alive to sue you. My mom or dad will be dead. But there are people like that. So I've heard like that. So, but at the end of the day, if you make the right decision,
I'll wait till she's unconscious, because before we had the other directives, I'll wait till she's unconscious and then I'll make the decisions.
And the people who scare you and threaten you that they will sue you, they will never sue you. People usually, but you should not practice. But yeah, thank you, Terry. And these are you're going to see, and you will learn from a lot of people around you. So good, thank you.
Thank you.
So this was our introduction. Sorry it took a little longer with the technical issues, but we do want to sort of capture the other objectives. So we talked a little bit about the ethics component, the communication between the nurse coming in, speaking with the doctor, and then going to speak with the patient about an ethical topic, self-determination, accountability, as Dr. Rashford and Anki just covered. We want to now move on to different objectives, which are part of the situational awareness as being a team member in an interdisciplinary team, professional team. We're going to have a high fidelity simulation activity. And for this one, we're going to need 4 medical students and 4 nursing students. All right, hands are up, fast. Got it. Come on up.
Come on, guys, volunteer.
Nursing students. Oh, they've been voluntold. They volunteered earlier.
Pre-briefing.
Okay. I'm going to go this way. And so this is going to be the second case in your scenario description, and we're going to be watching here.
Do you want to grab your IS card? Oh, I didn't get one, actually.
Just what you would have.
Do med students need anything?
No. It's going. So it's your head.
MDs.
Did you want them in at first, or them to run report just outside the room and then come in?
Yeah, the briefings.
I'm sorry.
The briefings, and then the
Report, will you report you?
in here.
Okay,
Oh, wait, we need to make sure that.
She's gonna give you a report? Yeah. You just make my signature. And what's the medication? And also the medication. Assessment? I would do like documentation for a charge. We're a team, guys. Yeah. Gotta jump. And I'll give you also as a resource for you. So you know anything you need to I'm gonna go blank. It's okay, you have the knowledge.
Okay, great.
We're
Let
ready
me go
to
ahead
go?
and put his headset on.
Are we ready to go? Sure. Yes. Okay. So we have to call the doctor. That's documented so that's when you guys will bring that lady called you. And the physician, you guys will go there. Yeah, she said she's gonna document anything related to the doctor.
You just state that you're the patient and you can be
I like that thing. There's a DJ over there, we tell him it's called the doctor's outfit. And he's gonna read it. Testing, testing, testing.
Oh, it may not be on to save the battery. It is really bad?
No. This is where this is at?
Mm-hmm. Blinking with no communication. Yeah, we're good. Yeah, but he didn't respond, you can't hear him?
I didn't.
Go ahead.
Message over to you? Yes.
And then I'll check with Ariana to see if he's recording.
Okay.
You said you were gonna let me know when.
Okay.
This is at 4 o'clock.
All right. Okay. Here we are. We're going to give, I'm going to be reporting you guys. So your patient name is Stephen Balry. Okay, so I'm giving a report. Your patient is Mr. Stephen Balry. He's 67, male. Height and weight is 6 foot, 280 pounds. Allergies to penicillin. He's a full coat patient. And patient chief complaint is shortness of breath. Stephen Baldwin is a 67-year-old obese Caucasian male with 10-year progression of severe right knee arthralgias from osteoarthritis.
no relief after multiple trials of high-dose non-steroidal anti-inflammatory agents, including phenylbutazone, disalcid, and most recently, Celebrex. Despite physical therapy and prior use of a knee brace, situation has deteriorated. Presently, pain significantly affects his ability to ambulate. Now able to walk only by cane. Joint pain is asymmetric. Past medical history, acute coronary syndrome, two vessels PTCA related to a non-ST segment elevation, MI, 6 months ago. Hypertension for the past 8 years have been well controlled on therapy. He has osteoarthritis for the last 10 years and major depression, depressive illness for the past 4 years. His medications are currently Lopressor or metoprolol, 25 milligrams BID, lisinopril, 5 milligrams BID, hydrochlorothiazide, 12.5 milligrams QAM, atorvastatin, 10 milligrams QAM, Bayer's aspirin, 81 milligrams QAM, Selecokid, which is Celebrex, 200 milligrams QAM, Ventafaxine, which is Effexor, 150 milligrams daily. Social history, he's divorced, retired construction worker, and he lives with a girlfriend. Vital signs, blood pressure 110/80. His heart rate is 130. Respirations are 22. Temperature 98.6 Fahrenheit orally. SpO2 is 92% on room air. And he has pain of 6 out of 0 to 10 on numerical scale. And that's it. Got it?
That's nice. Oh, no, could you repeat the medication dosing, please?
Yeah. So it's going to be Lopressor or metoprolol 25 milligrams, lisinopril 5 milligrams BID, hydrochlorothiazide is 12.5 milligrams every morning, atorvastatin 10 milligrams QAM, baby aspirin 81. You got it? Mm-hmm. All right, excellent. All right, thank you. Okay. Ready? One second, sorry. IV fluids, normal saline, 50 milligrams, milliliters per hour with PCA pump, patient control anesthesia pump, and that contains morphine infused at 1 milligram per hour with a 2 milligram bolus, PRN for pain.
I'm sorry, how many? 1 milligram per hour?
Well, yeah, with a 2 milligram bolus, PRN for pain.
So any standby order or anything?
That's it, that's all I have.
Yeah, there are orders in the chart.
Oh,
Okay.
patient is complaining of shortness of breath.
Okay, so.
There's no oxygen.
No oxygen.
He's gonna need oxygen.
How many liters?
He's gonna need 2 liters. So, until we can put it up to 295. And we have to maintain it at 95 or 2 liters. Where are the orders? Oh, these, okay, yeah. So the person that's
Why are the meds up there like this? Are we supposed to pretend that that medication is just sitting up there?
What is that medication?
So I'm like, I mean, we don't give pills, we don't know what they are.
Let's get started.
Okay.
Okay, so we go outside?
You can, yeah. We just need to get it.
60 to 70 seconds. Well, let's try that.
Sit down.
afternoon, Mr. Stephen Bowdre. My name is Salson, and I'm going to be your nurse for today. This is my team. We're going to be assisting you today.
Hello, I'm Deepa and I'm a charge nurse over here today.
Hi, I'm Lindsay. How are you feeling today? I see that you came in with shortness of breath. Oh. Okay, so you, yes, can you, can you please give us your first and last name and date of birth, please?
My name is Stephen Bowdre. My date of birth, 1/15/51.
Okay, and I see that you came in, what is your date of birth again?
1/15/51.
Okay.
Hard to breathe.
Oh, you're having a hard time breathing? Okay, we're going to be giving you some oxygen.
Okay, that's why I first
Okay.
called oxygen.
Do you have any chest pain?
No, just can't breathe.
You just kind of breathing, oxygen.
Okay, so I have another cannula.
Yeah. No, it's here.
Okay, I'm giving you some oxygen through nasal cannula, 2 liter. This is gonna help you like breathe a little bit, right?
And I'm also gonna listen to your heart and your lungs, okay?
Okay.
Okay, I'm going to be putting this in your finger just so we can monitor your oxygen.
That sounds good.
Okay, I'm doing it.
Okay, so the pulse rate is 136. That is 94%. Pulse rate is 132 right now, so please stand by or we
Yeah.
Oh, it's a retard. No, the breathing at the stick. It's a retard.
This is oxygen.
Yeah, no, oxygen saturation. Okay.
Mr. Bolton, are you getting do you feel any air coming through here?
Yeah, but I'm getting scared. I wonder what's happening.
Do you want
I
a blood
keep
pressure?
breathing faster, but still feel like I'm not getting, air. Kinda hurts my chest
Your chest is hurting?
when I take a deep breath.
Can you point to where it's hurting?
It's like inside my chest, but
Inside it hurts?
on the left side.
Can you describe the type of pain?
I don't know, it feels like there's something heavy
Heavy?
inside my chest.
Heavy pain? Okay. We just sent one of the nurses out to go get the doctor.
Yeah,
To have the doctor come in here and look at you as well, just to calm you down a little bit and make you feel a little bit better about what's going on.
maybe we can stay here a little bit more.
You want the bed up more?
Yeah. Just a bit.
The red part?
Even with the nasal cannula, oxygen saturation is still 91%.
Can we titrate it up or no?
How much is it at right now?
Is that 2?
On our physician order right now, we have only 2 liters, so Sujan just going to get the doctor. Maybe we can call.
I'm getting scared.
I'm right here, Steven. I'm holding your hand, okay?
I'm scared.
Try to just concentrate on your breathing. We're gonna get the, oh, here we go. The doctors are here, okay?
I've been trying.
Okay, so oxygen
Have you
saturation
guys
is
heard anything? Okay, Brandon.
Yeah.
Hey, Mr. Burry, we're here to help.
So he didn't get anything for the blood pressure?
Yeah, so we got an EKG. What seems to be a problem, Mr. Farid?
I'm sorry, what was the question?
What's the problem? What are you having difficulties with?
Just having difficulty breathing. I was just laying here and it started. Just getting scared.
Okay.
He said it feels like crushing pain on his chest, and he's having a hard time breathing. His
Okay.
oxygen was at 91 a little bit ago. We're at 2 liters right now.
Okay. And do we have an EKG? Can we put the beats on?
Sure.
Is he
Here.
cardio?
All right, Steven, I'm
We don't
gonna
have
just
it.
open this up
Do
a
we
little
have a
bit.
pulse?
The pulse is 132.
Did you give him fluids?
Yes.
Yeah, did you
He's
give
on
him
he's
fluids?
on IV fluids right now.
When did the shortness of breath start?
Oh shoot. Are there things on there?
5 minutes ago. Okay.
Thank you.
Well,
I think we should
Oh,
give
are there
him
any
some,
fluids?
I think we should give him some basic pressure because blood pressure drops a little more.
yeah, well, let's put the heart.
I feel like I'm not getting enough. And
Can we get him on a non-breather mask or change the, instead of the.
Yeah.
We should change that.
Okay. Connected. Yep.
What was your EKG?
We should do the, what's it, synchronized
Close.
cardio version since his blood pressure so low.
Is it all
Alright, Steve, we're gonna change the mask just to
No,
get
no,
more
sorry.
oxygen,
The heart rate
okay?
is up 160.
This will help get some more.
It has to be,
Oh,
above
okay.
the, okay.
So do you want it in a
Can we do
camera?
it,
See, that's it. Which
Can I feel the air?
I was just thinking of utero, like, for, to help the shortness of breath, but is he even MI or anything, or is he normal?
He's normal. No,
It's just he's tachycardia. Okay, so we just wanna slow his heart, yeah?
Yeah, I'd say give him epinephrine.
That's what we
Yeah.
said.
Wait, epinephrine didn't stop.
No.
That would increase heart rate, we want a slow heart rate.
No, it wouldn't do.
Cause he has a pulse, I think only do that every time.
What were the medications that were given him?
I think he had the blood pressure medication in the morning. Blood pressure.
You don't wanna have my emergency.
Can we run some live so we check his basic chemistry panel?
Can we give him Cardine? Since his blood pressure, 138, I'm sorry, can I see the blood pressure?
ABG, CBC, Chem 7?
Blood
Okay,
pressure
so
is
we got
very low
there.
like right now.
You wanna
It's
see
not-
that?
It's better than 130.
What is the blood pressure right now?
Blood pressure, it's low.
Is
96 over
96.
75, so we cannot give any.
Okay, so since it's 96 is, okay,
We can't, yeah.
Are there any abnormal labs?
No. Just glucose was
What about the EKGs? What's going on?
It's like,
He's a little acidic.
He's acidic?
On the low normal. But it's probably because.
What was he doing before?
Yeah, what was he doing before the shortness of breath?
He was just laying here.
Yeah, okay.
Steven, you weren't doing anything when you had a shortness of breath? You're just laying here?
yeah,
What's
His
his past
troponin
medical
is
history?
elevated. It's at
his
1.5.
past medical
So
history.
What was that again?
He has
Troponin.
He had an MI 6 months ago.
But his
He also
troponin
had an acute core
And
MI.
his GMP is also
He
elevated
has
at 200.
hypertension, but it's controlled. He has depression
He's what?
4 years ago.
EMP.
For 4 years, and he also has osteoarthritis.
So he's got heart failure.
We get a recent MI then, oh wait,
Yeah.
sorry, that's a
He
D.
had one 6 months ago.
Okay.
So do we get a D dimer? Well, I don't know if we can send it.
Yeah, we should, he was just having like sudden pain
No,
in
we-
his chest.
So can we start him on a
How long has he
heparin
been
drip?
laying in this
That's
bed?
I think we should start on head and drip. That wouldn't hurt.
Yeah.
Yeah.
Start him on a heparin drip?
What's the PT on him?
What's his?
Do we see his CT? Was that
It's
drawn?
not.
The result is not. Okay.
That's a low molecular weight.
For it.
Oh,
Because,
Cognizant.
oh, okay, well, then, I see, that would be under the, chemistry. Oh, here, PTT.
Oh, it's usually we have to put them on all.
Can we get him on like albuterol? Can we listen to, I guess, yeah, we can listen to his song.
Yeah.
Y'all listen to his song. Can you, I don't have my
So
sister.
here, here.
I'm gonna put them
Okay.
listen to the song.
Okay.
These heart failures, so, is his bedtime?
Okay, we're gonna sit you up so you can hear your lungs from the back. Is that okay?
Okay.
It should be or not,
Did we
what
do
can
it?
you
Did we check that? He uses a brace because of his osteoarthritis.
Oh, this is diminished on the right side, right?
What is this?
Lower.
Did you guys
So
do
do
an
we know
inspection?
if have you traveled recently?
No.
Okay, let's do,
an inspection.
we're gonna do a full head to toe
Okay.
inspection.
Alright. Okay, I'll do an inspection. I'm gonna inspect you now.
Did you get the inspection earlier? Can you tell us what you found?
No, it's okay, we can do it now. Go ahead, Fadi. We'll do the, you wanna do upper and we'll do lower?
Sure.
Okay. So, let's,
So when
Mr. Stewart, we're gonna look underneath this bandage.
Yeah, what is this?
He has a brace on because.
Oh, he had arthritis or something like that.
It just looks like.
Bleeding. It's like
Like the toe.
I think, did they know that we started, did we start that?
Oh, so this is the one that's.
Oh.
CBC? Oh.
Nurse,
Did you
start
recent
that?
surgery?
Did you have a recent surgery, Mr. Ball?
Did we start that?
No, we didn't start it.
Yeah, can we do that? What do you do?
I don't think
Knee replacement of
I don't think
medication?
you should.
So it's most likely it's a P.
Yeah.
Yeah, it's a demobilization. So yeah, we definitely wanna do the heparin first and then the warfarin, and we can test for D-dimers.
Yeah.
That's what we wanna do. What are we gonna put the heparin with?
Oh, like how many units?
So we didn't learn that, do you guys know? Alright, heparin drip.
We have not learned that at all.
Do we have anything on our, in the drip? Probably not.
Is that what they asked?
I mean, cause if we're doing a drip, we have to know
The
where
target and right.
Okay, phone's up to date.
I don't have heparin here.
Does anyone remember?
No, that's
Do
fine.
we have to put
Maybe we
the
can start
CT
putting
scan
out.
or not?
Sorry, what was that?
Maybe we can start putting out the heparin drip bag.
We can prep it before we get the dosage, yeah, let's do that.
Do we do the best
Should we get the heparin on the pressure or?
No,
I
I
just
think
check and see if it's there.
It should be, maybe the first one.
So how much fluid is she getting?
She's getting 50?
An hour?
Yeah.
50 milligrams an
Blood
hour.
pressure is
And
up.
Okay, it's going up now, that's good. I'm taking these. Except for 10. It's usually small. Should I just pretend it's a heparin?
Oh, never mind.
Okay.
We have to go to the different IV line.
So with PE, you said
Does he have any allergies? or any-
Yes, to penicillin.
To penicillin, okay, just wanna make sure.
What's his weight?
280
pounds.
10 pounds.
What is it?
200?
280.
No, I don't think I have any allergies.
He doesn't have allergies.
No, we have him got penicillin.
Oh, yeah.
I'm
Yes.
allergic to penicillin.
Okay.
Yeah, that's what it is.
Okay.
There was some those medications on your general surgery, what about just for?
That's
Maybe
not,
that's-
that's it. What is it?
Did you not take the medication? Were 5,000 these, units. yeah, were these your medications from this morning, Steven?
Yeah, 5,000. Or 80 per
Is there-
kg.
Did you take your medication today or no?
10,000 units. Since it's
I don't know what
Since
they
it's what?
have here at the
It's
hospital.
80 per
These
kg
were-
Tell you what I take at home.
but he's heavy on the
No, do you see these? How do you know? I just found these on the
280.
table, was this Okay. from earlier Then I'm today going that with they didn't give to
Yeah,
you?
I'd say 10,000. Give him 10,000
Sorry?
units.
I have these medications I just found on the table over here. Did the nurse earlier give this medication to you, but you did not take it yet?
Yeah.
No, I haven't taken anything yet.
You haven't taken any
I already
medication
told
yet?
you dilute that one,
Yeah.
that's why it's 10,000 units.
So we're missing
Yeah,
that.
go ahead and do what I said.
Because I think it's going to dilute 10,000 units, it's not direct 10,000 units of the current.
Sure.
I
Okay, diluted is
Right,
fine.
right.
Diluted will make sense, but like direct, apparently.
Okay, diluted is fine.
No more.
Okay, maybe we can confirm on that one because we need like kind of on.
Confirm.
Yeah.
Okay, simulation is over.
Okay.
We don't even know if this
Let's go
medication
back
starts.
to
No, we're not gonna
2:35.
It's not safe.
Okay.
What happened?
We're
Did we fail? He didn't die.
Yes, he did. He's
He's
gone.
fine. Look at his. He actually.
No,
his blood
he
pressure's
died.
going up. He's fine. Oxygen's 95.
Oh, I feel like I died with him too.
Right? We're all like.
Don't worry, we take care of that. So just
We talked amongst ourselves because we were comfortable, but I tried the cross. Hopefully it got better.
Well, that was fun, right? We're all like, oh my god.
But they were trained.
But they had assigned roles. We amongst us, we didn't have assigned roles.
Well, even though we did, we still like. I mean, never keep our still like, not just like
Come on, darling, come on.
That was like the best class ever.
What was the scenario? What happened? I know he got it. Why? What was he there for? He had a bunch
You can monitor.
Oh, really?
I heard your call.
But it was like.
But did you guys double check the cutting his letters?
No,
So what did you guys get in the report?
It just came with the gift card. And then we had to. I think I had.
Yes, that's what probably I don't think that was that. That's like not too ending day. Okay, what you're doing talking for a long time. I don't think I made it no big deal. I don't know what made them look at the blanket. But I don't think I made it no big deal. I would assume.
And I'm so glad that the
But I don't think we had good communication. I wasn't talking to anybody.
That's literally the point of the exercise.
No, I know.
Yeah, so they were saying Jasmine was doing synchronized cardiovascular. They're just thinking of how to drive this thing. Maternity.
Are you going tonight?
Oh,
Okay. That's the balance.
Yeah, I guess so. But I was thinking the last trip. I did for That's the goal. We stick with us. The hardest goal.
All right, so let's take a little time. I know we're running up against the clock here. But we do want to sort of take a little moment to debrief the encounter. Let's hear first from the people in the actual patient room, and then we'll give you our perspective regarding the objective that we discussed earlier. So, who would like to share the nursing perspective? Nursing students, yes?
It was a little bit of nervous. I was really nervous. But I think that getting the report and then doing the assessment, like the patient was basically crashing when we first walked into the room. It was like a little shock for us. So I think communicating with the doctors is the most important part, but at the same time, it's also difficult because we don't want to step our boundaries. So sometimes you do want to suggest, but then you hold yourself back because you always feel like they're gonna know more than you.
Wait till you get to the wards.
But I think we did have like a pretty good flow, and we were all listening to each other. And then I felt like we were like the doctors were listening to us, which is very important. And then we were obviously listening to them as well. So I think overall we did good working together.
Yeah.
I don't know if our patient survived, but
Oh, yeah, you did great. So you started in the room at the nursing assessment initially, assignment, and then you went over and communicated with the doctors. What was that like telling the doctors? Were you thinking IS bar? And doctors, were you hearing IS bar? Were you expecting that? Were you thinking in those terms?
I'm very used to communicating with using the IS bar. It just gives me an easier flow on what I need to tell them and how to direct them to the main problem. But yeah, that's what we would use. It personally helps us more than to help us focus instead of just going around in circles.
The doctors, were you expecting an IS bar report, or were you just like, hey, what's going on? What do you need? Do you have a strategy to listen, way of capturing the information, or?
Yeah, I mean, we didn't know what we were expecting in the empty call room, whatever we were at. But she came in, and when she started talking, I was expecting the IS bar. I mean, and she did it in order, and then after that, we didn't know what's gonna happen or what we were expecting. And I don't think me and I speak to myself, I guess. I don't think I worked in my best abilities in there as a doctor. I was like always trained in a sim lab with a lot of MDs, and I was just talking to anybody that was wearing white. I did talk to the nurses, but mostly to anybody that was wearing white in that room, because that's what we used to in the sim lab. And I acknowledged it in the middle of it. I kind of like sensed it, so I tried to change it, but I don't know if it worked or not. But that's from my perspective.
So you noticed that you were more comfortable talking to other doctors than to nurses, even though the whole team was trying to figure out the puzzle of what patient
And I like kind of in the beginning when we walked in, we didn't take a good history, we didn't do a physical exam. I was expecting it's already been done by the nurse already, so I'm already walking in with like that mentality, which is wrong.
Yeah.
I just didn't know who's doing what.
How did you face it? Go ahead.
I felt kind of the same way. Just like it was a little bit of confusion among like the white coats. Who was doing what?
Yeah.
And then
you didn't have one, 2, 3, 4, 5, 6, 7, 8.
We usually assign team roles, but we weren't sure if we were supposed to assign ourselves. The nurses were already already had their stations, and then we were like, well, I don't want to double up on what someone already else has, so I guess are we just like all team lead and then we decide, which was kind of confusing on our end.
Yeah, and then also like it was confusing because we didn't know what roles the nurses were doing as well, so we didn't know how to like At least I felt I didn't know how to like effectively communicate because I didn't know who to ask for what I needed. So
Yeah. So
I think it was sort of like being a different coming in with everything already, because usually we take the history and we find out what happened to them, so it's so much easier to treat that way. But like I think if I did it again, I could orient myself better, like that everything's already done. You know, like it's okay, Jasmine, it's already done. Like
some of it was done, but then we didn't realize the physical exam.
Yeah, some of it, right, but that
we
was
didn't realize that till
disorienting
later.
at first. I think doing that differently.
So that was the part that was missing that you think would have made you more successful? That physical exam?
it would have helped.
Yeah.
Okay.
Also, having my ACLS book would have been helpful because Jasmine was on the right track, and then I just didn't know the rest of the mnemonic we learned. So. But I wanted to point out about speaking up on nurses. I don't know how other medical students are taught, but we were taught specifically that you guys are basically on the same level that we are. In fact, you might know more than we know. So please, like, whenever you're like practicing and whatnot, please speak up because we're still learning and we can learn from you too. So.
So watching you guys in the room, I saw a lot of really nice things. You guys were talking to each other. At one point, I did see the nurses all go to one side. I was curious what you guys were talking about, what you were trying to figure out. What were we talking about? Remember?
I remember that too. Oh shoot, we're doing what we're not supposed to be doing. We're clicking. Not that we were trying to like be clicking, but we're like.
It's like natural to
Yeah,
just go with your comfort.
I think that, like, because I think we told y'all to do, but y'all felt a little apprehensive about it. And we were like, go ahead, like, you know, and I think it's okay, you can trust us, like, we're going to take the fall for it. Go ahead on and do it. Like, not y'all,
So I just wanted to concur what you said, because we were sitting here watching, and I said it too, and I was like, I noticed how it just, at first it was like come in, and then at some point it just became like white coats and then blue, and it was like, oh, okay, what's going on? I don't know. But going off of what Jasmine just said, I think it's obviously a mentality we all need to like work on, and the idea of asking to do instead of telling to do. Maybe that would cause people to want to talk to each other. Like, can you please do this? The nurse is gonna do it. Like, so doc, I don't think this. Maybe we should. I think that people respond more to like being asked rather than just assuming that they did it, and then I said, oh, did you guys take the blood pressure? What is it? Or something. I don't know. Then you like open up that communication out.
Then to assume that everything
that
was
is
already
done, and then like oh, they're
we walked in just like a few minutes before, so sometimes it's also better to not assume and just ask if we did it or not.
Yeah, I want to say that, you know, there is no right outcome for this. What we're talking about is the outcome. Noticing the importance of having a team, knowing who's in charge, knowing who does what part, and what things you need to do for yourself, what things you can hear from somebody. You know, so somebody said, blood pressure is low, let's give fluid. And you said, somebody's to the lungs, right? Yeah, I think they were clear. Before you proceed with that volume, whoever's doing that should check that there's not a CHF situation and that there's patient's fluid overloaded already, right? So there are some things you're going to do yourself. You're going to use the assessment, incorporate it. But everybody did just fine because the bar was set very high. You guys have not practiced. You don't have a coach, a captain, or you had any practice. So don't feel that you didn't perform at a certain level. This is what we expected. Just to bring out these communication gaps. The goal is the more you do it, the better you get at it. And if you're in the ER, you're gonna, the triage nurse is gonna see the patient, assign a specific type of room, and then typically it'll be additional assessment from the nurse, and then that will be communicated to the doctor. The doctor will go in, make their own assessment as well, work together with the nurse. And so it is hard to figure out all those things you brought up. But that's kind of the point of this activity, is you never practice on your own. And so knowing what to expect is important.
I also wanted to bring up, did you guys notice the little Easter eggs we planted in the scenario? Some things that were wrong? Maybe what are some things you guys noticed?
Those meds really bothered me.
Okay, there was a pill cup with a bunch of pills in it. We don't know where they came from. We don't know what they were, what dosage. Okay. Anything else? There were a lot of them.
For me, it was hard to know what was his heart rate because there were two sounds going on, three. There was the breath sound, there was a really fast rate, like a heart rate, but then there was another sound in between. That the alarm.
There's an alarm of tachycardia. So there's every heartbeat has a sound to it, and then there's alarms for parameters that you set. So it's intermittent. Go ding, ding, ding. And then there's a beep, 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 beep.
Oh, that's
Would you spend a month in the ICU or ER? You're gonna be able to pick them apart.
Yeah,
Right now,
I wasn't sure which was
noise.
which.
Yeah, but it's important because you can, once you're situationally aware, you can walk into a room, either visually or audibly, tell whether somebody has a regular rhythm, it's fast, it's slow, there are pauses. Again, this takes time. And what you're asking about is situational awareness. Here in this room, we saw right away there was one situational awareness that was captured or something that was noticed. You guys see what it is at the very beginning? Like, no, the people who are not over there, but in this room watching the video. Tell? You noticed something. Yes.
Oh, the wristband?
Yeah.
Yeah, I'm like.
We can tell from here without audio even.
He said the last name weird, and then I was just like, well, maybe that's just how you say it, okay. But then he said the date, his birthday, and I'm like, this guy's confused. He doesn't even know his own birthday. And then I looked at the chart, and then I was like, okay, so because we've been in sim before where it's wrong, and so we're like, oh, this is sim. We're pretending like it's right. So I'm like, are we pretending it's right, or is it really wrong? If he doesn't know his birthday.
That was, and from here, even though the audio was a little obscured, just in your body language, I observed you sort of signal to the other person like it's not right, and so we'll receive that information. It's not right. You confirm with a chart.
Well, I confirmed the birthday. Yeah.
We both did. Okay.
Yeah.
So what did you think at the time? Should we just proceed? This is just pretend. It's supposed to be right, but it's not.
Yeah, since the wristband was wrong, the chart was right, and he knew the birthday. Then we were like, okay, like. They're on the same page, like there's just a mistake in
So you
in the
confirm
wristband.
chart and patient saying wristband wrong.
Yeah.
Right.
Okay. So past history, allergies, if you check for any of those.
We did allergies.
Because you gotten a sign out from which patient? The chart patient or the wristband patient?
I'm sorry? Wait, what was
The chart, the sign out you got from your nurse.
Our report?
Yeah.
She told us
He told us
penicillin.
that
She gave us report.
Who? Stephen Balry or?
For Stephen.
No, the
The nurse.
well, she said the patient's name, which name did she give you?
Oh, that was right name.
Right.
Oh,
That was the right name.
Yeah, right.
Okay, so only the wristband as far as you know.
The wrist, yeah.
So whoever puts the wristband puts the allergy band typically, right? Was there an allergy band?
Actually, there was a red band. I don't remember.
You were right there. This is what I could observe.
It would have said written what he was allergic to.
It was red, right?
Did you guys notice what was hanging on the pole? There was an antibiotic.
Yeah, I did see that, and I was
Okay,
like,
so,
oh, what is this? And I was looking at it, and I was like, is this a med that just be giving? Like, what's going on with this? But we were trying to figure out the heparin situation too.
Well, because he had said that he told the med students that he was not allergic to anything. And then when we told him, we were like, no, penicillin. Then he was like, oh yeah, penicillin. Like, so I could have been a little confused.
So again, in this scenario, we try to make everything real. We don't want you to suspend your disbelief, and that's just something that you want to clarify before proceeding care. Make sure you have the right patients. It could be just a banding error, but yes.
In real life, like I was working at Memorial West, and so this is back to the band situation. So I was transporting a patient to go get an X-ray.
Yeah.
I'm looking at my chart. I'm looking at the patient. I look at the wristband. The chart says female. The wristband says male, and she looks like a female.
Yeah.
And I'm like, well, in today's age, you never know. And I'm like, I'm not gonna ask because I'm like, I don't even know what protocol is. Like, do I ask her? Because normally you ask name and date of birth, but I'm like, that's the right person. So I'm like kind of confused. Take them to the procedure, and I say, hey, I think there's an issue. Like, I don't know, maybe she is a male. I don't know.
Yeah.
And then so what they did was they called registration, and then they said, oh, yeah, that was an error. So I have no idea how long it went on that she was wearing a male band, but she was actually a female.
Right.
So that does really happen.
Yeah, no, it happens all the time, unfortunately. And this is what we're talking about medical errors, where you have the right order for the right patient, but you give it to the wrong patient. And it's happened to me personally, as a patient too. So it's everywhere. These are sort of, we have checks and balances to try to avoid these things. So let's just talk about a few other things that were observed. For me, from my perspective, I saw sort of the moment in which the group realized what the diagnosis was. And it seemed from here to come when the X-ray came. That was a very dramatic. You'll never see that. That's like a one-time, like wedge-shaped sort of infarct. Very rare to see. So it was sort of a gimme, just in case you guys were stuck. The X-ray would save you. It seemed to have saved you. But I was curious in terms of the stage at which that information was available. What was the team thinking about? What is wrong with this patient who recently had surgery and is suddenly short of breath?
Volume overload.
Okay.
That was my thought.
Sure. Yeah. Did anyone else know that he was thinking that?
I guess on my part, I actually didn't know that he had recent surgery until we inspected the patient. Like, I didn't put that all together. If I would have put that together, I would have thought PE and like added to the like differentials. But the only thing I had in my mind was just like shortness of breath. Think of albuterol and the MI. And then once the EKG came out clean, I was like, what? We're missing something.
Was it necessarily clean? Was it perfectly clean? Did you guys notice? What did you notice?
The PE findings, but I found it after I found the X-ray.
Okay.
Because I was looking for an ST.
I saw you go and check. You saw the X-ray.
Then I went
you
back.
said, let me go check the EKG. Like, oh, there it is. Right? Okay. That's fine. That's sometimes the way it happens. But going back to the history, I'm curious where that was captured. What was the history of the recent surgery, even before you examined the leg?
I mean, for the medical students, it wasn't exposed the history of him having a history. We didn't ask him, and we didn't ask the nurse.
Were we told? Because I
No,
don't
we were not.
You weren't
We
told?
were not told that he had a surgery. Yeah.
So,
We found it
it's funny, like the
So that came up on exam, like when the knee was bandaged. Like, oh, what happened here?
He was leaking through the bandage.
Okay.
As soon as I saw the knee, I was thinking pulmonary embolism.
So you saw the knee, and that was your trigger for thinking about pulmonary. So again, it's a stepwise process. When multiple people are doing multiple things, sometimes the most obvious basic history, like past surgical history, right? Have you had recent surgery? Oh yeah, I had surgery in the knee, which is a great sort of risk factor for pulmonary embolism a week ago. And suddenly now I have sudden onset shortness of breath. So just again, situational awareness, roles. Who's going to ask all the questions? Who's going to make sure that all the questions are asked in the right order? Was there one person assigned to taking a history from the nursing point of view or from the physician point of view? I couldn't tell from here, so we missed a little bit of it.
MDs, we didn't do it. We thought of maybe having a team lead, but we didn't get past it.
And from the nursing team, did you sort of have a little huddle to say who's going to do what? Obviously, you went out to talk to do the communication, but any other roles assigned in the
Yeah, we had like the assessment, like the vital signs, the assessment part, and then we had a medications nurse that has to go out and get the meds.
All right, so you did, that's great. That's what you want. You want to have people to have assigned roles, not to, So I'm curious, who thought of the right diagnosis first? Nurses, doctors. Who was thinking about? Was it before? Did the knee get exposed before the X-ray?
No, the X-ray.
No, X-ray first.
Okay.
Then he happened like the last minute during the simulation. It was like accidental findings.
Yes.
But when we walked in, we were like pulmonary embolism based on the survey we took.
Well, yeah, but that's why I was like, do you have chest pain? But he
Yes.
said he didn't have chest pain.
Yeah.
Yeah,
So that's a good point. With that kind of peripheral infarct, a lot of people pulmonary don't have chest pain, but if we're going to give you that picture of an infarct right next to the pleura, that person probably would have pleuritic chest pain. Was it the right? It was
Yes.
It was the right. So yes, that doesn't quite line up, and we probably should put a little less obvious example of that. But this is again, there was no right answer or endpoint you were looking for, because it's really about how the team roles were assigned, how the teams communicated, and we're here in school to learn these things.
I think we were scared at first too because he wasn't responding. We're like, oh my god, he's already
Oh,
not responsive.
the
But then
simulation hadn't started
But
yet.
yeah, she told us she's like it's rebooted. We're like, okay, so we're like,
Yes.
is he with us?
Yeah, we had a few technical issues today. Any other, any other last minute situational things? There was sharks in the field.
Oh yeah, there was sharks popping out of the sharks container.
Oh.
And there was a syringe plugged into the IV bag.
What?
Yeah.
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 I didn't notice any of these things.
Gorillas are coming out of everywhere. There's
How did we
gorillas
not
everywhere
see
now.
that? There was bloody gloves
Yeah.
on the keyboard on the computer, bloody gloves. His phone was tangled in the rails and hanging on the floor.
Oh yeah,
Man, we
oh you did
yeah.
Did you? That's when I noticed that he had the catheter. I was like, oh, he has a catheter. Okay. I should have seen it safe. But I saw it was on my side.
Some of these things are for Euro safety. You know, some of the gorillas that we placed in this video.
Was his bed up really high too? 'Cause I feel like he was high.
He had a rail down. You guys noticed that?
Yeah, I
He had
know.
one down.
I was trying to figure out how to pull it up, but I noticed on my side. I just was like, where is it? Is there even a? I could. Yeah. I should have did more to like find out where it was, but I noticed it.
Okay. See your job, guys.
No, I'm saying like thinking I'm like, I was like, okay, at least we could. But you know what? Now I won't make that mistake. When you walk in the room, because normally, like when I walked in the room, I was looking for oxygen because I knew that already. When we got a report that his oxygen was 92, so I'm like, okay, there's no oxygen up. So I'm like looking at that stuff, but I wasn't thinking of a glove.
Right.
And then the Foley, I guess we could have thought about for the kinking, like if we were monitoring input output to look at it and see if it wasn't working, then oh, is there kinking? Yeah.
I don't know if it was.
I wish we had more time to review, but I love that thought, that concept of next time I do this, I'm going to pay attention to all these things. You know?
Yeah, we want to do it
It takes
again.
a lot of time, but practicing, you know, and then having a coach or a captain. So all those things, that's the purpose of simulation, is to be aware of gaps in your skills and knowledge, to get better as you do it. I think we have to wrap it up.
Yeah. With that being said, there's a post test you guys have to do. Same thing as the pre-test. You would access it the same way. Do you have it?
It's the first slide.
So you'd access it lsmiramar.rossU.edu. You can complete that at the same 10 questions. And then we can finish up.
Please, also there's an evaluation.
And there's also an evaluation.
Well, let's give results.
Oh, wait, yeah.
We
You
get
can
the
watch
results.
this.
Do you know the results?
I said, well, let's give. We didn't
Like
do
if we
it,
didn't take the pre-test.
You all got A's.
Okay, so.
We
Don't
did
worry
that.
about
They're
it.
asking if it's post test.
When you do the evaluation, you will get it.
Can you put the
For the post test.
There we go.
There's one more video.
Maybe they can do the evaluation. Just complete the evaluation part.
I'll show you this whole view. Everybody has the other?
It's the same one as the pre-test.
It is, yeah.
So the same test.
We just want to know if you
Changed.
improve.
Oh, I've seen this.
I want you to do something very important, all right?
Okay.
I want you to run home and I want you to call the ER of North Bank General Hospital, 932-1000. Tell them to set up OR6 immediately and
Really?
contact anesthesia. 2112.
Look at her little face.
Line ID B5 and W KBO. You got it?
ER North Bank General Hospital, 932-1000 said. OR6 contact. Anesthesiologist is George Torque, 472-291-2212. Ambulance with paramedics and line D5 and WKBO.
That's good.
Sounds like a subdural hematoma to me.
Well, it's not your job to diagnose. You thought, just go. 3 years of nursery school and you think you know it all. But you're still way behind the ears. It's not a subdural hematoma, it's epidural.
So we hope
I just read so many.